which is very important and practical topic, that the journey of cardiology in SRN hospital. So it is important as how it has evolved the department of cardiology over the time, and what are the current facilities right now running in the cardiology department. So I'll invite the chairpersons for the same, and I'll request Dr. Manoj Madhav sir. He is the professor in the Department of Medicine. Now I'll request Dr. Mohit Jain sir. He is the professor in the Department of Plastic Surgery, MLN Medical College. Now I'll request Dr. Poonam Gupta ma'am. She is the senior most professor in the Department of Medicine, MLN Medical College. As the chairpersons to introduce our speaker.
A very good evening to all of you. Dr. Abhishek Sachdeva is the Associate Professor in MLN Medical College, Prayagraj, and he is also the pioneer for starting the intervention cardiology in the PMSSY wing of MLN Medical College, Prayagraj. He has been born and brought up in Prayagraj, MBBS from the prestigious Grand Medical College, Mumbai. He has done his DNB from Delhi Max. He is the ex-consultant in BL Kapoor Hospital, Max Hospital, Rajiv Gandhi Super Speciality Hospital and United Medicity. He has the privilege of doing more than 3,000 cardiac interventions, including angiography, angioplasty and devices. He is director of Asha Heart Care and Research Center and Non-Invasive Center in Prayagraj. He is fellow of Asian Pacific Society of Intervention Cardiology and International Associate, fellow of European Society of Cardiology, life member of Indian Academy of Echocardiography and Indian College of Cardiology, member of National Academy of Medical Sciences, have been an active member as speaker and faculty in various national and cardiology forums. He has various publications in reputed national and international journals. So I request Dr. Abhishek Sachdeva to start his talk.
To respected chairpersons, and thank you sir for the introduction. I first of all thank all senior members who are here. So basically my talk is what we are doing in SRN Medical College, because there is lots of confusion what we are doing, what we are not doing, and how is the department wise, and what emergencies we are handling, what procedures we are doing. So journey of cardiology in SRN started in the year 1979 under the guidance of HOD Professor R.K. Agarwal sir, with an ICU bed strength of 4 in the old building SRN hospital. The department was shifted to its current building in the year 1992 with 6 ICU beds and 12 general beds under the guidance of HOD Professor P.C. Saxena sir at that time. The new ICU which is currently there, we have a separate cardiology building with a strength of 10 beds, was started in 2003 and was further expanded to accommodate 20 beds in a year. In the year 2009 under the guidance of former principal and HOD Professor P.C. Saxena sir. Currently, the faculty, the department is looked after Dr. Piyush Saxena sir, Associate Professor, we are 2, Dr. Abhishek, me, myself, and Dr. Mohammed Shahid. And assistant, we have right now a big team, Dr. Vinay Pandey, Dr. Amish Shukla, Dr. Nikesh Mishra, and two persons have joined as a bond, Dr. Vimal Nishad and Dr. Vaibhav Srivastava for 2 years. So along with this, we have 6 PG residents, 2 in each year, posted around the clock. So there are 6. And some non-PGJRs and interns are posted in ICU from time to time. Total ICU beds which we are managing right now is 20. We also get ICU beds on request in PMSSY 3rd floor and medicine ICU. The cath lab is situated in the 4th floor in the PMSSY building, where we have a console of 12 beds more, which is everything is monitored and everything is with invasive BP monitoring and everything. Our current workload, SRN Cath Lab is the only government cath lab in the district. Cardiology department has a total IPD capacity of 38 beds, including ICU of 20 beds, which are always working with more than 90% capacity. We daily thrombolyze around 5 to 8 myocardial infarctions. That is the biggest MI in anywhere across India in the center. Non-invasively, we are doing daily echoes, TMTs and ECGs. So the cath lab was installed. All are real pictures from the SRN cath lab. This is a real picture. So cath lab was installed before COVID wave. However, since the whole PMSSY building handled COVID emergency, cath lab was started in April 2022. So because COVID changed the dynamics, and this is the cath lab. Now what procedures we are doing in SRN cath lab? That is important what our city is doing. So we are doing angiographies. We are doing mostly radial angiographies because of two reasons. First of all, patient compliance is better. He is early discharge. He is mobilized just after the procedure, and we don't need to admit them. After 2 hours for observation, which we keep after the angiography, we discharge them. So we are doing mostly radial cases and very few femoral. So patients don't need IPD stay. They are discharged the same day after 2 hours of angiogram. If angioplasty is done, we recommend 24 hours observation. We have in-house OCT machine, which is installed now. With the help of Boston Scientific, we also do regularly rotor ablation for calcified lesions along with IVUS guidance. So we do imaging, intracoronary imaging, which is a very useful step in assessing whether the stent has expanded or not, whether the plaque is significant or not, or what actually is there at the micro level. So we also do percutaneous balloon mitral valvoplasty. BMV is actually recommended for symptomatic patients with severe mitral stenosis who have a favorable morphology and absence of LA thrombus or any MR which is greater than moderate to severe on transthoracic echo. We also do balloon angioplasty for coarctation of aorta, which has all these have been done. So this is how a BMV does under fluoroscopy guidance, and we insert a pigtail and then the wire and then the balloon. Electrophysiological study and radiofrequency ablation. So this is the next level which we have started. An EP study is a test to measure the electrical activity of the heart and to diagnose arrhythmia or abnormal heart rhythms. Catheter ablation is a procedure performed to treat some types of arrhythmias. So we do that in a lab. However, we have a specified date and time because we have one lab, we have a huge MI load which you can see. So when we are planning to do an EP study, we have to stop it for angiography or angioplasty, because you never know when you get into an EP how long it will take, whether you will be successful or not. In angioplasty is 99% we are successful. The time duration also you cannot predict in EP and RFA, but in angioplasty is in 80% time you are right that you will do this in 30 minutes, 20 minutes, 1 hour, 2 hours. So that is the issue. When we do an EP RFA, we are normally keeping it in a 1 day in a month. And we plan the procedures, we plan the patient then. EP RFA is not an emergency thing, that patient cannot wait. They are having symptoms from months to years. So we do it in an elective date. So this is how an EP tracing looks like. Very fascinating as a graph, but difficult to interpret and infer. Pacemakers, this has been done since last 30 years. Initially was done under C-arm support. Now we are doing in cath lab with better lead placement and thresholds evidence. ICD and CRTDs we also do. CRTD is an implantable cardiac resynchronization therapy defibrillator for patients with reduced heart failure, reduced EF in heart failure. A device monitors heart rhythm, detects irregularities and corrects them with electrical impulses. So CRTD is a device which we do in SRN. Now even the government has capped the prices initially, which we did last month. It was around 7.5 lakhs in a private setup. That cost come around to 13 to 14 lakhs with device. In our setup we only took the charges which were mentioned in PGI RC. That was 7.5. Now with the latest RC, the CRTD price have been capped to around 4.91 lakhs. So just as we discussed a lot about ERNI, and which has been a game changer for patients with heart failure, device again will be another game changer, especially for patients with reduced EF. So CRTDs do differ from ICDs in the way that they help the patients, the cardiac resynchronization, the AV synchrony is maintained, so the EF improvement is a possibility. Again, CRTDs have 3 leads and wires that deliver energy to the heart rather than 1 or 2 as in ICD. So this is how a CRTD looks in the fluoro. It has 3 leads, one in the RA, one in the RV, one in the LV, which we have gone through the CS ostium. Renal coiling and angioplasty, we are doing renal angioplasty for significant renal artery stenosis and coiling for renal artery bleeding after a PCNL or other procedures. Peripheral angiogram and angioplasties also have been started. Again, we have planned, we want to upscale and we want to upscale our services. So we are planning for device closures for ASC, VSC, PDA, pediatric cardiology interventions. Tower is our next step, which we are planning, might be in another 3 to 6 months. And tricuspid valve interventions are also new, especially in patients with RV dysfunction, severe TR. So our current data, if we talk about till March, we started in April 2022. And since up till March 31st, 2024, we have done total interventions 3074. Angiographies we have done 2100. Angioplasties around 972. Pacemakers we do around 15 to 18 per month. And till date, mortality on table has been 4. We don't say we are not getting the bookish mortality, but getting for a cardiologist, it is always a nightmare to get a mortality while doing an intervention. As per bookish theory, 2 to 4% do land up with stent thrombosis sooner or later. So I don't think we all are well, all are doing good. But mortality on table has been very less because we have been very careful in selecting cases, doing the high risk casing, doing the high rewarding cases. So currently we are doing around 8 to 12 angiograms daily. Angioplasties we do 3 to 4. Our waiting time is still nearly 2 to 3 days for all panels, Ayushmans, BPL, and especially with HAC fund also, which we are working. Any patient who doesn't have any money, even we write a letter to CMO fund and we get the approval within 2 to 3 weeks. And pacemakers, as and when required, as CHP comes, we properly after 24 hours maximum, we do the procedures. So waiting time is nearly 0, and only in cases of some Ayushman, we do wait for the approval. However, if it is emergency, we do write to the Ayushman and we get the approval immediately or after the procedure. So what are the future prospects? The whole cardiology building is under renovation, which is expected to get completed before December 2024. The department initially, now when we joined, was limited to ground floor only. Now again the first floor development maintenance have been started. Our seminar room, library and everything have been under construction. The contract have been given. So we are planning to start DM course so that our care of patient goes to the next level. That we have realized no matter how hard we work, we need a working hand, we need a post-op care which is better. Plan is to get IVUS, rota, laser and a cath lab in cardiology department itself. Currently we are cardiology department is cath lab is in PMSS 5 4th floor. So down the line when we get a PG course, definitely 2 cath labs will be there. We are also planning to start pacemaker and arrhythmia clinic as early as possible, and budget also have been sent to the government for a new echo machine with pediatric and TE probe. Because for device implantation, we do have the patient, we do have the needy, but for transesophageal echo, we are still handicapped. So personally, our observations during the past 1.5 years, that is for the reason for increased cardiovascular morbidity and mortality, is poor symptom recognition, often amidst comorbidities led to delay in seeking healthcare. Distance between patient home and nearby medical centers have adversely affected the outcomes. Lack of skill at small center led to delay in referrals. No primary management was given at the respective centers whenever the patients have come from acute ACS or MI. And surprisingly, till now, all ACLs do come from their own or public transport. None are transported through ambulance. High rate of comorbidities were found after the management of ACS in terms of dyslipidemia, type 2 diabetes, hypertension, again emphasizing the importance of preventive health checkup. Our nursing staffs and residents managed post-PCI patients to their best effort. However, since the beginning, there were many doubts about sheets, stents, OT, diet, mobilization, monitoring, emphasis on drug compliance. I still remember an incident when a patient was bleeding after an angioplasty. She was having some oral bleed and the sister told her that because the stent went through GI tract, you are bleeding, it will subsidize after some time. So again, the patient ignorance have been there, but now the solution is also there. So the patient education is the key to success. We did our job the best in the cath lab and we knew nothing is going to happen in the console because everything depends on inside how things you have managed. So we, as even today we in our rounds do emphasize on every visit regarding diet and drug compliance. Everybody in our unit spend time with the patient and try to understand his or her concern. We never push patients for complete, we do culprit artery only in acute ACS. We don't go beyond culprit artery because we feel like it is more economical, beneficial for a patient, for us to save a life. After 2 years, because just of our patient effort, drugs and follow-up compliance in most our OPDs is more than 80%. So we have very less loss to follow up. Even the patients are poor. Once they put once the stent is there, we do emphasize on the importance of diet follow-up. We also want him or her to come in the OPD and have a regular follow-up, because for 6 months or initial 3 months when the stent is endothelializing, everything is very different. So we have identified multiple issues that are related to access, including transport, geographical distance, delays in patient seeking care, access to diagnostic center, ignorance, ability to pay leading to delay in appropriate treatment. I individually have realized patient education and society awareness can bring actual difference in CV mortality and morbidity. I tell you a very important event. I was STEMI coordinator in MAX. So my duty was to ask most of the consultant why there was delay in STEMI. We do follow protocols like eliminate all doors in STEMI. Yeah, so in MAX there was a protocol of eliminate all doors once a patient STEMI comes in the ER. So they announce STEMI, code STEMI, and then the patient is not stopped on any door. He directly goes to the cath lab. But then also in retrospectively, when we asked the consultant why this patient came at 118 and angioplasty was done at 145 and how to increase the load, at the end of the day, it's a corporate hospital. They wanted more STEMIs to come to them. So a senior cardiologist at that moment told, you cannot bring 50,000 people and make them stay near MAX and wait for them to get an MI to increase your load. The solution is society education and early treatment. Let them follow a pharmacoinvasive protocol also, which is not at all bad, which we are following in SRN hospital. We are very few doing primary angioplasties because we don't want to waste patient time of making him understand what is primary angioplasty. We thrombolize him on the first instance so that it saves the time for us to talk with him. Streptokinase is available inside the hospital most of the times, otherwise he or she can purchase it. It costs around 2,200 only. So we are doing less of primary and more of pharmaco-invasive, where patient is thrombolized and later taken for angiogram to see the lesion. So especially as the talk started in the beginning, when the West is talking about primary prevention, we have a lot to achieve, especially in terms of secondary and tertiary. Primordial prevention is a new concept, not new, but we are lagging a lot behind. So in the end, we do face many difficulties, but I would say where there's a will, there's a way, and it's an old proverb which I strongly believe in. And I would like to give my special thanks to our past principal, Dr. S.P. Singh sir, and PMS SMI in charge, Dr. Mohit Jain sir, who stood right behind us at every step. So thank you, and this is all what we are doing. We are doing all interventions in SRN, and we try to do it on time. Thank you, sir.
Excellent presentation, Dr. Abhishek. Very happy to see the development in the Department of Cardiology of our hospital. And I am the proudest person because, when I had gone to finalize the equipments for our super specialty block to the ministry in Delhi, they had put tremendous pressure on me to cancel the cath lab because the total cost, estimated cost was increasing by exact the same amount as the cost of the cath lab was. But I refused to budge and cancelled many other equipment, but I didn't cancel the cath lab. And I told them this is the need of my city as well as my college, and I will not cancel the cath lab. So I am the proudest person to see you people working, and I see every day in the OT, because the cath lab is in the OT complex only. So I see how hard you people are working, doing at least 12 to 15 procedures every day. And I think it has been a great service to mankind of this region. Thank you so much.
Thank you, sir. In fact, you are responsible for these 972 lives which we have seen. That matters a lot. They would have not been there, for sure. Because all our cases are class 1 indication. We never did a class 2A or 2B indication. We just believed in saving lives.
Hello. This was very nicely presented. Each and every detail was presented. I think most of the people may not have any question, but still if they want to inquire anything, they can ask. And I would like to give a very big statement that this was a blessing to the pure soul of the doctors that this has come into play, and my father has himself benefited because of this department, and many fathers of many faculties have benefited, and you all can ask now whatever if you have any query.
I would like to inform everybody that the cost of the hospital charges for angiography is 1100 and for angioplasty is 3300. That is the total user charge which the patient has to pay, apart from some of the consumables and the stent which the patient obviously has to pay himself.